For our next speaker, Eugene, is going to talk about risk stratification of acute pulmonary embolism.
Hi, how are you? Can you hear me okay? And can you see my screen?
Yeah.
Thank you so much to the organizers, and thank you so much for inviting me to speak about this topic, which I'm passionate about and I think is important to bring to attention. So I'll start with the case. This is a 64-year-old man that we saw after recent CVA. So he had a stroke about a month prior to presentation and went thrombectomy and had some residual aphasia. He then presented to outside hospital with some shortness of breath and generalized fatigue. He had a workup that revealed positive biomarkers with troponin and BNP being elevated. They did a left heart cath as they thought there was an acute coronary syndrome. It didn't show any obstructive disease. He then underwent CT angiography that revealed a settled pulmonary embolism and occlusive bilateral main PA clots, and then he was transferred to our facility for further care for possible advanced care. These are his labs. So he had, like I said, slightly elevated troponin and BNP. Lactate was slightly elevated. He was a little bit tachycardic, but blood pressure was okay. And he was significantly tachypnic and required quite a bit of oxygen, 10 liters per minute, and only satting 94%. This was his CTA on presentation. You can see here he has a subtle embolism, so straddling the main PA, and then more importantly, he had occlusive clots proximally, and his RV was significantly dilated. This is something we look at for every CT. So his RV to LV ratio was significantly more than 1. It's probably 1.5 range. This is his echocardiogram to orient you. This is left ventricle, left atrium, and right ventricle. Again, striking is that right ventricle is significantly larger than the left ventricle. And then you can see that there's something, a mass or thrombus that's going in and out of right ventricle and right atrium. This is a TE that was performed, and again, to orient you, left atrium, right atrium, SVC, IVC, and here you can see a clot or a mass that's straddling the PFO and going across the PFO from right atrium into the left atrium, which we did not appreciate on the transthoracic echocardiogram. His lower extremity Dopplers revealed residual blood clots at the level of the knee and below, bilaterally. So this question often comes up in our practice is how do we manage these patients who come in with acute PE and some high-risk features? Do you just anticoagulate them and monitor them? Do you jump to systemic thrombolysis with all the risks associated with that? Do you go for catheter-directed techniques with either catheter-directed lysis or percutaneous embolectomy or surgical embolectomy? Those are the tools that are available to us, but not available to all institutions. So the objectives of this talk is I'd like to talk about the RV anatomy and physiology, RV interdependence, and then different techniques that we use for risk stratifying these patients with acute PE, which I think is the real meat of the matter. So the right ventricle is really not the same as the left ventricle. They operate on very different curves, pressure volume curves, and they're coupled to very different circuits, where LV is coupled to low compliance, high pressure circuit, and right ventricle is coupled to high compliance, low pressure circuit. So you can see that with the small rises in blood pressure or ventricular load, the left ventricle can tolerate it over a wide range, where the right ventricle acutely fails and there's a big drop in stroke volume. And a lot of that has to do with interventricular interdependence. The RV and LV are connected both in parallel and in series. So in series, the output of the RV really determines LV preload. And in parallel, is because they share the septum. So anything that happens on the right side ultimately affects the left side as well. So as RV dilates, LV has to be compressed. And again, that hampers the LV preload and LV output. And coronary perfusion is very important as well. This is normal coronary perfusion. On the left side, it happens mostly in diastole because it depends on the the gradient between the MAP or the mean arterial pressure and LV pressure. So in systole, there is no gradient, and diastole, there is gradient. On the right side, that's very different because that gradient is maintained throughout. And what happens is that RV coronary perfusion happens in both systole and diastole. But what happens in acute PE, you have acute rise in PA systolic pressure, acute rise in RV and diastolic pressure, and you can have decreased RV coronary perfusion even in the absence of epicardial coronary disease. And that leads to early decompensation and really starts the circle of death, as we call it. And this coronary perfusion really is a threshold phenomenon. It operates between 40, 50 to about 110 millimeters of mercury. But as you reach that threshold, it's not a linear relationship. The coronary perfusion plummets and the RV stroke volume plummets with it. So in terms of classification, we classify or try to put these patients into three main buckets based on mainly hemodynamics. So there's a high risk or massive PE, there's intermediate risk or submassive PE, depending on which side of the Atlantic you're at. In the United States, we call it submassive and massive, and European Society of Cardiology defines it as high risk and intermediate risk, and then low risk. And this is the pie chart demonstrating the prevalence of all of them. And then this is more talking about more granular definitions of them. So the low risk P is normal blood pressure, normal right ventricular function, normal biomarkers, and it's really associated with low mortality, but it's a heterogeneous group of patients. And submassive is normal blood pressure, but now you start to see RV dysfunction, elevated biomarkers such as troponin and BNP, and it's slightly higher mortality. And the massive PE is a broad category of patients who have blood pressure less than 90 for more than 15 minutes, or requiring vasopressors or inotropes, or suffer cardiac arrest. So very different patients, as you can see. You can have a patient who comes in with a blood pressure of 89 and otherwise looks okay, be classified as a massive PE. And then you can have a patient who is suffering from cardiac arrest, also classified as massive PE. But so it's really not a perfect classification system. It leaves a lot to be desired. So in terms of pathophysiology of PE, it really depends on two things. One is the embolism size. This is from a classic paper from Mood in 2002. And the other thing is the cardiopulmonary status. So, and again, it's not a linear relationship. It's a curvilinear, and there's definitely an inflection point. And now our job is to figure out what that inflection point is. For patients who are low risk, it's very easy to find them, identify them, and they're okay with early transition to home with outpatient management. And those patients who are at high risk are really easy to identify as well because they're crashing and burning. And again, you want to escalate therapies quickly because a lot of them will die within the first hour of presentation. But really, we need to figure out this group of patients who are in this intermediate range. And we don't really know if they're high intermediate, low intermediate, and that's what I want to focus the rest of the talk on. And this RV spiral of death has been described many, many times. A patient comes in, they develop RV strain, then drop in RV contractility, RV ischemia develops, as I talked about, from coronary perfusion, and then LV preload goes down, LV output goes down, and then you develop hypotension, and then you have an organ perfusion deficiency, and then cardiogenic shock and death ensues. And again, we have to get more granular, and I'll get more into that. So again, this is the ESC risk stratification, talking about high risk, intermediate risk, and low risk. And as I talked about, it depends on RV function, it depends on hemodynamics, and this pulmonary embolism severity index, which I'll get into next. So the pulmonary embolism severity index was developed to help stratify patients. It's a lot of clinical parameters, a lot of demographic parameters, and some presentation parameters. And then they devised a simplified version of the score. As you can see, it's quite cumbersome to calculate. The simplified version is a little bit better, but still not great. But really, the strength of the score is to identify low-risk patients. When they looked at the validation cohort, you can see here the sensitivity of the score is very, very high. The simplified version is 96%, and the negative predictive value is over 99%, meaning that if patient is low risk, based on the score, patient is low risk. But you can see here that the positive predictive value is pretty bad, 10%, meaning over 90% of patients that we classify as elevated risk based on the score will go on and be completely fine. So a lot to be desired for. So this is where the other markers comes in. So this is looking at RV dysfunction, and we know that if patients with acute PE have evidence of RV dysfunction based on RV hypokinesis or further stratified by positive biomarkers and RV dysfunction, they're at a significantly increased risk of early mortality and poor outcomes. Blood pressure is another early marker of disease. So again, if you have patients with low blood pressure, so hypotension, less than 90, it's associated with increased mortality. And this goes back 30, 40 years that we know this about this. But now we know that it's probably a little more nuanced than that. It's not simply dichotomous variable, but it's more a continuum of risk, where patients with lower blood pressure are at significantly increased risk, not just at the cut point of 90, but probably along the entire curve of the risk category. Another risk marker to look for is the presence of concomitant low extremity DVT, because the patients who present with PE to the hospital already self-selected themselves as survivors, so to speak. And the thing that's going to kill them now is a second hit phenomenon. And that second hit can come from a couple of places, and low extremities is the most common one. So this meta-analysis from a few years ago looked at concomitant low extremity DVT and found that patients with residual DVT had about twofold increased risk of mortality after PE. Clot in transit is another potential source of second hit. So this is another study out of Europe that looked at right heart thrombi and found that patients, all comers with acute PE, had an increased risk of mortality if they also had clot in transit. And same thing is for high-risk PE and low-risk PE. So this is something to look out for, and this is where echo comes in very helpful. PFO is another marker of disease. We found that patients with patent foramina valley at about 11-fold increased risk of in-hospital mortality and complicated course and ischemic stroke and peripheral embolization as compared to patients without PFO, and also increased risk of death. Whether that risk is pathophysiologically driven or whether it's just a marker of disease, it's unclear, meaning that is it just that you have high risk of peripheral embolization and that's how you die? Or does it mean that your right atrium and right ventricle is so dilated from acute PE that you're just identifying patients with bigger RAs and bigger RVs that are high risk for mortality? That remains to be seen. And there's never been a study that looked at PFO closure in these scenarios and looking at outcomes for these patients. Lactate is a very good marker of progression of disease. Again, there's a stepwise progression for patients with a higher lactate are ever increased risk of mortality after acute PE. So again, this cut point of 2 seems to work well, but again, you can see that there is a nice stepwise progression. Other factors, you can put them all together and look at cardiac biomarkers, BNP, RV dysfunction, presence of low extremity DVTs and PESI score, and find that all of them are independent predictors of mortality. But the downside is that even if you take all of them together, you still end up with a positive predictive value of about 21% or so, which again means that over 80% of patients with all these high-risk features are still, most of them will do completely fine with conservative management. So how do we figure out who is at high risk even better? So one thing that you can look for is cardiopulmonary status, and that's the right side of this graph. So how do you do it? Do you do it subjectively? So anyone with some sort of cardiopulmonary disease, such as lung disease, or anybody with heart failure, or can you be more objective about it? So can you look at markers of cardiac index? So obviously you're not going to put in right heart cath and a swan and every patient comes in with PE. It's probably not prudent and it's probably frankly dangerous to do in acute PE, but there's other markers you can look for. So our group looked at predictors of cardiac index in patients who come in with acute PE. So we selected patients who were undergoing catheter-based treatments, so they had to have a right heart cath because we were doing a procedure on them. And then we looked at retrospectively at different markers of echo parameters and found that RVO-TVTI is a very powerful predictor of cardiac index, independent of everything else, and it's actually the only one that's independently predicts it. We found that cutoff value of 9.5 centimeters carried pretty reasonable sensitivity and specificity with the area under the curve approaching 0.8. And it's fairly easy to perform. We do it all the time for PE patients and non-PE patients. We can do it in multiple windows. But the point is that anybody can do it, and it can be done at the bedside without moving the patient. And we found that it's a marker of early PE-related mortality. Another group from New York found that looking at LVO-TVTI, which is a very similar concept, obviously, and they found the cutoff of 15 is associated with shock or reperfusion therapies with 8-fold higher chance of needing reperfusion therapies or ending up in shock or even dying. And there's other echocardiographic manifestations of acute PE that may be helpful. Again, RVO-TVTI, LVO-TVTI, patent foramen valley incline and transit is what we talked about already, and RV to LV ratio. TAPSE is a powerful predictor of early bad outcomes as well. And then 60-60 sign and McConnell sign are commonly reported, but unfortunately they don't carry as much of a prediction as these other more objective measures do. So back to our RV spiral of death. So as you can see, we can start to fill in some of these parameters. So RV strain, RV ischemia, we can look at troponin and VNP, and blood pressure we can look at as well, and cardiogenic shock, and death is obviously very close to tissue hyperperfusion, which is measured by lactate. But we can start to fill in the other parameters as well by looking at echo parameters such as RVO-TVTI and LVO-TVTI, and really trying to get granular information about our patient's risk and who needs to be intervened on early and to prevent in-hospital decompensation. So back to our patient, as you remember, it's a 64-year-old gentleman with very recent CVA and now coming in with large occlusive clots and big RV and a PFO, which is with the clot straddling it. So we thought that anticoagulation is probably not enough for this patient. She's too high risk for that. Systemic thrombolysis probably carries a risk of intracranial hemorrhage. That's probably unacceptable for this patient. So now you're left with either percutaneous devices or surgical embolectomy. And we thought that going in percutaneously, you can dislodge this clot that's across the PFO and cause more harm than good. So we chose surgical embolectomy for this patient. So this is the video from the surgical specimen. So you can see this patient is cannulated in the SVC and IVC, and this is the right atrium that's opened, and you can see this large clot that's being extracted. That's what's been straddling the PFO, and then in this video you can't see it well, but the PA is open and they're pulling out a massive amount of clot. And you can see here, this is the surgical pathological specimen. This specimen is from across the PFO, so this was on the left atrium side, this is on the right atrium side. This is what we saw going between RV and RA. And these specimens are from the septal embolism and then from different branches of the PA tree. So what's important to note is how different these clots are. It's not all acute clot. Some of it is chronic, some of it is acute on chronic. So to think that systemic lytics or catheter-directed thrombolysis will take care of all of that is probably not the case. So we need to figure out how to treat these patients better and how to predict which patients will respond to catheter-directed lytics or systemic lytics and who will need either percutaneous embolectomy or even surgical embolectomy. So a lot of work that still needs to be done in this field. So to summarize, the risk stratification of patient selection is critical. The typical classification that we use is probably not enough. So we need more risk factors that are more geared towards each patient and more individualized for each patient. And team approach is really essential. That's where the PERT team comes in. The pulmonary embolism response team has been started a few years ago in the United States, but now has really gained international attention, and it's been really in the forefront of leading the research field. And then there's a pert consortium that's has a scientific meetings, and we're in the 7th sessions of it, and it's exciting to see that this year we're teaming up with Jack Case Reports to present the best science and pick the best cases from the meeting to present them. And I thank you, and I'll look forward to the discussion.
So thank you so much. Actually, this is an amazing case, and I wonder the outcome. The patient is doing well after the surgical embolectomy, and I think.
Yeah, patient.
No, okay. So my question to you: if there is any reason for this massive, horrible pulmonary embolism in such patient, did any investigation trying to show this is a provocable pulmonary embolism or non-provocable?
So this patient did do really, really well. He was discharged to rehab and has been doing really good. So for him in particular, we thought that stroke itself is a major risk factor, stroke and immobilization, and he has residual weakness that led to immobility, both of the limb and over the whole body. So that led to his provoking factor.
Okay. And in such patient, would you recommend in the next future to close this BFO or not?
So that's an excellent question. And this is a data-free zone. And on one hand, you want to close the PFO, but the question is when to prevent future strokes. Because if you close it too early, you take away the pop-off valve for the RV, and you risk the RV decompensation and patient going to worsening shock. If you close it too late, you probably worsen the risk. There's a risk of recurrent embolization. So for this patient, it was an easy decision because it was a time of the OR. We closed it because all the clot was already removed and RV function recovered. But for patients who were doing it percutaneously, remains to be seen when and how they should be addressed.
Okay. So I have a question here from Dr. Ayman Khairi, then Dr. Sobhi will go on to ask his question. Okay, Dr. Ayman?
Thank you very much for this elegant talk. I would like to ask you about two things. In this patient, why didn't you, he was not shocked, so as an intermediate high-risk patient, why didn't you you cannot give thrombolytic, why didn't you give just heparin to follow up and see what's going to happen? Because surgical embolectomy actually in Egypt is not an option. Most of the surgeons don't like to do it because it's very high risk. And in this situation, we mostly will give just anticoagulation and follow up once the the thrombus in transit is opened and dissolved. We will put a big tail in the pulmonary artery and give half dose specific thrombolysis. What do you think about this strategy?
So that's a very interesting approach. So one is surgical embolectomy is an interesting question. So historically, it's been done in patients who are crashing and burning and on the verge of either performing CPR or on the verge of crashing to CPR. And those patients, you're absolutely right, do very, very poorly. The idea is if you're going for surgical embolectomy, to go early. So if you go early, the outcomes are very, very good. There was a recent case series that was published of close to 200 patients who went surgical embolectomy out of New York, and they've done excellent. And the main predictor of poor outcome was decompensation on the time to the OR. So again, if you wait for the patients to be coding or be putting an ECMO, you're probably going too late. So in experienced hands and with the right team and right approach, the idea is to figure out which patients are on that cusp of decompensation or which patients you should be moving forward who will not be good candidates for just anticoagulation. But vast majority of patients will be treated with just anticoagulation alone. You're absolutely correct. But we think that looking at these individual markers such as RVO-TVTI, LVO-TVTI, and we're looking at other markers on CT to help us figure out which patients have low cardiopulmonary reserve and low cardiac output, and who will not tolerate another hit, who will not be able to wait more.
Dr. Sobhi?
Yeah, yes. I was interested in this talk. Thank you very much. You add to me a lot, but I have to add two things and then I ask questions. Any patient, an elderly patient, unexplained dyspnea, you should suspect pulmonary embolization. The second, that you have to search for hidden malignancy. And most of the patient elderly for the recent time, that's like maybe the answer of Dr. Sada. Why don't search? Not hypercoagulable, it's rare to be in 67. You should search for, sometimes there is a hidden malignancy like prostatic or bronchogenic carcinoma. My question to you, your experience in your center regarding the catheter-directed thrombolysis or suction, because also in Egypt, we don't have good experience in this, although we read a lot about this, but we don't have this facility to be aspirated. We aspirate the thrombus in the coronary arteries, but we don't aspirate the thrombus from the pulmonary artery. I don't have the retrieval of this. Maybe in cerebral strokes they aspirate, but we don't do it in pulmonary. Can you give us what are the types and what is the indication for this? Which subtype of patient you need to do catheter-directed thrombolysis?
So there's two things. One is we are in a world where we have a lot of catheters now that are available, which is great. And the bad thing is there's very little data to guide us on which catheter to use when. So we have catheter-directed thrombolysis, simple infusion catheters, the Unifuse, Grant McNamara. If you can pair it with the ultrasound-assisted thrombolysis with ECOs, or you can use suction thrombectomy such as a NARI device or the CAT8 or CAT12 device from another company. And all of them work really well at reducing RV dysfunction and reducing PA pressure and removing clot. But other than surrogate markers, we don't really have data to guide us. Anecdotally speaking, from my experience, we're shifting a little bit from catheter-directed lytics to suction thrombectomy, percutaneous thrombectomy. Again, this is with very little data to guide us, but the experience has been very, very good, both from patient symptoms and safety.
Thank you.
Thank you again for your elegant presentation. You mentioned that we have a thin line between the different risk stratification of pulmonary embolism. So many patients with pulmonary embolism, we will see right ventricular dilatation and such as reduced VOT, VTI, and LVOT, VTI. But if you see a patient with right ventricular dilatation, would you go to advanced method other than the anticoagulation, rather than systemic thrombolysis or catheter-directed therapy, or you would do a more risk stratification regarding these patients?
So we found that RV dysfunction, RV dilation is a very, very early marker of PE. So what happens is RV dilates very, very early to maintain stroke volume and maintain cardiac output. But a lot of them, vast majority of patients, probably over 80 to 90%, recover without any advanced therapies. So even in patients with positive biomarkers in RV dilation, you can still see that it's very early marker. It's not, it doesn't define a category of patients who will do poorly yet. So as a routine, we do not proceed. We follow these patients and then see how they do. 8% yearly. And then look at other markers and really engage the patient in these discussions for the risk of bleeding and risk of decompensation.
So thanks so much for your time and for your information. And we really enjoyed your lecture.